Welcome everyone, and thank you for joining us for today's webinar. I'd like to mention a few things before we get started. Today's webinar is being recorded. A link to the recording will be sent later this afternoon. You can find a copy of today's presentation in the handout section of your control panel. Simply click on the file to download it. Following the presentation, there will be a question and answer session. We encourage you to submit questions at any point during the webinar using the questions section in the control box. Jane, I will turn the floor over to you.
Great, thanks, Shelley. Good morning or good afternoon to everybody. My name is Jane Lutz, and I am the Executive Director here at the Pharmacy Benefit Management Institute. Welcome to everybody, and thank you so much for joining us today in our ongoing webinar series. I certainly hope that everybody has had a great summer, and as summer's winding down, getting ready for fall. Today we're pleased to bring to all of you a sponsored webinar that focuses on a very important and growing topic in the healthcare industry, and it's the use of opioids. First of all, I want to personally thank our sponsor, Broadreach Medical Resources Incorporated, for their sponsorship of this webinar, which makes the event free to all of you that are listening. As you can see by the numbers, I know we had a very high number of registrations for this event today, but this is a topic that's also very important to all of us. We've all seen the staggering statistics over the past year about the use and the misuse of opioids and prescription painkillers. Some of the stats are staggering. It's been reported that in the United States, there are over 4.5 million Americans who are addicted to opioids, and over 2 million of them are abusing opioids with no legitimate need. Not only do these drugs take away pain, but they've also taken away the lives of millions of people. So let me introduce to you the folks that we have with us today who are going to talk a little bit more about this topic from Broadreach Medical Resources. Timothy Teen is the president of Broadreach Medical Resources, and joining Tim is Dr. Elliot Berkovitz, who is a PharmD and also their Director of Clinical Services. Also joining them is Dr. Calliope Panagos, also a PharmD and their Director of Clinical Operations. So at this time, I'd like to turn the presentation over to the team at Broad Medical Resources to walk us through the presentation. So go ahead.
Jane, thank you very much. I'd like to thank you and the PBMI staff for giving us this opportunity. And when I look out across all the attendees, I'd like to thank them for attending. Most of them from their capacity look like they're fellow colleagues and industry experts. And I would like to say thank you for joining us today. We want to begin by telling you we do not have all the answers. This is a very difficult problem. It's a very complicated problem. We certainly know all the questions to ask, and I hope that by raising this amongst our colleagues in the industry, talking about a few case studies and how we've been able to remediate the situation, I'm hoping from this what would be a fantastic takeaway is additional collaboration going forward amongst us and our colleagues in attendance today. So thank you for that opportunity to be here. This is not a sales pitch, but I think it helps that you have a little background on BMR so you know our perspective. As an organization, we've been in business a little over 13 years. We operate under a fully transparent and fully pass-through pricing model. So in effect, we do not play spread games. We're not doing any rebate games. Effectively, our entire focus is to drive the cost to the lowest net operating cost for our plan sponsors. With that in mind, we also include a high-touch clinical services model. And it's the combination of that high degree of clinical expertise that we bring to our clients, combined with the fact that we try to drive down cost and waste whenever applicable, that kind of led us into understanding and seeing this problem from a different perspective, as we'll talk about today. What I would like to do at this point is introduce Elliot Berkovitz, who's going to speak a little bit about the problem, and we will begin our webinar now. Elliot, if you would be so kind to take over. Ellie, you may be on mute.
Thank you very much, Tim, and thank you everybody for joining us today. Good morning, good afternoon. We'll start off with some statistics before we dive into the problem, just to go over the scope of the problem. The new drug crisis today is addiction by prescription. Addiction is defined as compulsive need for and use of habit-forming substances characterized by tolerance and well-defined physiological symptoms upon withdrawal. But how do we recognize the difference between an addict and a patient with legitimate need? Well, a patient with legitimate need is characterized by improvement of function upon relief of their pain. In this case, it's medication. An addict is usually the opposite. Calling it new is really a bit of a misnomer because spike did start more than 30 years ago, but it became more of a runaway train at the turn of the 21st century. One of the largest contributing factors then was the beginning of the fear of undertreatment, as everybody's heard of. It started with the famous case a doctor was sued for $1.3 million successfully by a family of an 85-year-old man whose family felt he died with his cancer pain improperly treated, and the 9-3 vote of the jury said physicians' lack of attention to pain constituted elder abuse. Now, hearing this, obviously everybody was very afraid to be sued and had a lot and began to fear of undertreatment. The opioid use disorder members have healthcare costs that are 8 times greater than those who do not. That resulted in $78.5 billion total economic loss in 2016. The plan sponsors absorbed 92% of that. Opioid sales as well as opioid overdoses have quadrupled since '99, and opioid use accounts for over 500,000 ER visits a year at a cost of about $5,000 per visit, not counting those that go to the units. The U.S. consumes more than 81% of the entire world's oxycodone supply. That's the main ingredient, that's the ingredient OxyContin, as well as 98% of the world's hydrocodone supply. For the past 5 years, there were over 250 million prescriptions for opioids per year, or more than 1 opioid per U.S. adult. More than 15% of the U.S. population is on at least 1 opioid. Blue Cross Blue Shield reported opioids were filled by 21% of their covered population in 2015, which was a 493% increase in just 5 years. Overall in the U.S., opioid use disorder tripled for patients on private insurance. According to the Surgeon General, 90% of the over 2 million opioid use patients did not receive any treatment for their addiction last year. There's great variation by state, but the trend is clear. The problem is getting worse. Opioid deaths are greatly outpacing car accidents, suicide, even breast cancer. It's now the #1 cause of accidental death in people over 50 years old. To look at one state for an example, Maine's opioid death toll was only 34 in 1995, climbed to 376 in 2016, at more than 10-fold increase to more than 1 a day. 50% of the opioid overdose deaths are from fentanyl, which is a legal prescription. And many of the supposed heroin overdoses now are being found to actually have been fentanyl, just mislabeled as heroin when it's sold on the street because it's cheaper and easier to get. In many areas, coroners are running out of room for bodies in the morgue, even renting refrigerated trucks to expand their capacity. The 2017 numbers are expected to be more than 100 deaths per day across the nation, and that's expected to be more than 250 deaths per day in less than a decade at the current rate. The next decade, we'll see more than 500,000 opioid use deaths if this isn't corrected, which is more than HIV and AIDS killed ever. This is not counting the spread of new super potent synthetic opioids, such as carfentanil, which is nicknamed elephant tranquilizer, and kills people with just a few grains of it, such as cases of law enforcement agents that have been killed by accidentally touching it and having it absorbed, whether it's through their eyes or other sources. Luckily, many new initiatives have emerged, and some predictions say that we could get this under control with an expected death toll of only, quote, 22,000 a year. Although certain groups may have a higher risk, opioid overdose can affect anyone. It knows no bounds of race, creed, or age. Some of the saddest cases are children that accidentally ingest their parents' supply, or unintended victims that we're seeing now of opioid orphans, as they're being called. Next slide.
Thank you, Ellie. Those are quite startling facts. The current opioid epidemic is undoubtedly a complex and stubborn problem. How can we, as pharmacy benefit managers and general pharmacy industry representatives, experts, and advocates help create change? It is important to recognize that well-thought-out PBM practices can make a large impact on this, the deadliest drug overdose crisis in U.S. history. Let's learn how. Today, we will focus our attention on the following learning objectives. 1. Understanding the scope of this growing addiction and warning signs for intervention and strategies that can work. Next, identifying how the 4 Ps of the pharmacy ecosystem, that being the patient, the prescriber, the PBM, and the plan, have, in terms of ethics, the impact to the human, proper controls, as well as direct and indirect costs. We will learn how proper engagement strategies combined with thoughtful, proactive communication can positively impact the pharmacy ecosystem, help the patient, as well as save the plans from unnecessary costs. Next slide, please.
So let's look at some of what's being done currently. There's been an increase in regulatory implementations. There have been recommendations from the CDC. In 2000, the Drug Addiction Treatment Act was introduced. It increased the range of the prescribers that could write for drugs that could treat drug addiction, such as Suboxone and Methadone. More recently, guidelines and regulations have been emerging that limited the initial opioid RX for pain to 7-day maxes. So you can't write for 30-day prescriptions as very often was being done previously. But there is no quantity limit. So you can call it a 7-day supply and give 500 tablets. Of course, the DEA can come in and ask questions later to the doctor, to the pharmacy, but there is no limit on that. In the 90s and before, as the DEA intensified its drug war, illegal drugs became harder and harder to get. The cost of them became higher, and with RX opioids becoming more prevalent, the competition increasing, costs going down, they provided the easier access to the high. The shift became from the illegals over to the legals, and you started having what's called legal junkies in the pharmacy world. The DEA has been meeting with the wholesalers and requiring them to inspect the usage of their client pharmacies to prevent this, to see which pharmacies are giving out too many controlled substances relative to their overall prescriptions. The DEA has also created provider and prescriber databases to keep better track of who's writing for which prescriptions, who's dispensing it. That cuts down on doctor and pharmacy shopping, most notably with cash prescriptions. The great thing about this is it catches instances of stolen prescription pads, which were very hard to prevent previously. Getting back to the 2000 Drug Addiction Treatment Act, that was when we saw the approval of Suboxone, Subutex, which previous to that, we had nothing really to treat drug addiction. The only thing available was Methadone, and there was a very limited amount of prescribers that could prescribe it. With all these new drugs came out, we had naloxone and naltrexone, the active ingredients here, along with the buprenorphines. The generic tablets for these only cost about $30 a month. And then you have the injections, which cost maybe even a little bit less. Some hospitals have been preparing generic injection kits they've been giving to their residents and the physicians to walk around with, teaching them how to spot opioid addiction, opioid overdose, and who to inject. They've even been training and supplying the local police departments. Throughout the country, everybody's seeing the ad campaigns to increase awareness, telling everybody that they should be carrying these rescue kits. One of the most popular ones, the most popular and only branded one, is the Evzio, which is a prefilled naloxone pen that the hospitals are giving out for $25 or less. But the Evzio is selling for $5,000 per syringe in 2017, when in 2014 it was only $690. So keep that in mind. Addiction treatment in the form of Vivitrol, another newer agent, which is a once-a-month injection, which mitigates the high and prevents patients from either getting the high or making it harder for them, has a cost of $1,570 a month, whereas Subutex generic buprenorphine tablets are still relatively cheap, but it is being replaced with the branded Suboxone Zubsolv films, which cost about $500 for every 30 films. With the advent of all these reversals, saving medications, and treatments, there has been a new fad we call the edge of oblivion. What happens is patients take the opioids till the point of near death, till they're turning blue. They have a friend nearby with naloxone, naltrexone ready to go, and they eject them right at the last point. And that is something that is driving up costs there as well as increasing the use. That's something we also need to keep in mind. We can look at the Middletown, Ohio council member, Daniel Picard. He said, it's not that I don't want to treat overdose victims. It's that the city can't afford to treat overdose victims. So this is something that's really, it's spiraling out of control in every sense, both from direct costs and patient lives. Next slide, please. Moving on to some of the punitive measures that have been put in place. The Department of Justice has been leaning on wholesalers. The wholesalers have been in turn leaning on pharmacies, cutting off their supplies, saying, we don't like your dispensing habits, we're not going to supply you anymore with the class 2 narcotics, etc. One example was McKesson, a very large wholesaler, had a settlement with the Department of Justice for $150 million, and that was just for failing to detect and report suspicious orders. Not that they did anything wrong, but they didn't catch other people for doing things wrong. So we have monetary fines. Doctors, pharmacists, pharmacies have been losing their licenses. People have been going to jail. And then, of course, you have the drug manufacturers themselves that are being sued. The average settlement now is $300 million per case just to avoid a civil trial. Some examples are most notably in Ohio, where they're suing Purdue, Endo, Teva, Johnson & Johnson, Allergan, claiming they targeted susceptible prescribers in the vulnerable patient populations. To put a number on it, Purdue's revenue on OxyContin alone in 2016 alone was $31 billion. Ohio's suit against them alleges that a well-funded marketing scheme led to its residents receiving 3.8 billion opioid pills from 2011 to 2015, fueling the human tragedy of epic proportion. Fatal drug overdoses in Ohio have soared by 642% since the turn of the millennium. Next slide, please.
Thank you, Ellie. So how do we begin to interconnect the solutions we just heard about, the regulatory and punitive, those of our governing agencies and policymakers, to form a comprehensive approach which PBMs can and should apply? It's important to understand that a PBM represents a valuable partner for the employer, the client, the plan, to understand the extent of the opioid use, how we work together to provide a very holistic solution. Looking at the problem on the whole across the entire system enhances our ability to determine the appropriate care, the appropriate medication, the cost, and the place, resulting in the best overall outcome for the patient and plan. Using PBM technologies offers opportunities to deploy a variety of flags when prescriptions are either misused or abused. This type of data and analytics are imperative to the overall approach. How does the system help us provide retrospective and current utilization data to evaluate how much prescribers are using opioids, what the dosing levels are, and what the duration is? How many fills is the patient making or attempting to make, and how can we capture that very important information? Having a system sophisticated enough to properly identify when an individual is seeing multiple prescribers for the same drug. How do we target and then contact the high prescribers and outliers is key. Similarly, being able to use the system monitoring tools to identify when a patient is pharmacy shopping, or having the very important flags in place to pick up early refill requests, which signal potential non-compliance to the prescriber recommendations. System flags should also be in place for dosing levels, including morphine equivalents and high daily doses, which can result in fatal overdose. Building your system to employ a duration of therapy limit identifier so that it can trace changes in opioid prescriptions while maintaining overall duration monitoring. And lastly, using technology to capture when opioids may be combined with other medications, whether that's chemotherapy, naloxone, and especially benzodiazepines and sedatives. So what then? This data is obtained through careful system setup, but must be linked with an emotionally intelligent and insightful clinical PBM team, one that can demonstrate a reflective and effective approach. Having the capacity to apply humanistic professional competencies such as empathy and compassion to the vital communication that must take place between the prescriber, the pharmacy, and the patient. Here is where change happens. Applying customized approaches, whether those are in lock-in programs or patient prescriber tracking programs, is important to help patients work towards a change and work towards progress. Engaging practices will foster successful outcomes. To help build the entire picture, we also engage with the employer or client to determine absence analysis, or how the use of opioids may impact the workplace, such as productivity, days missed, or sickness. Being very sensitive and cognizant of patients who are seeing different prescribers, whether for cancer pain or other conditions which may fall outside system flags. Remembering that the goal is always to ensure legitimate, clinically justified, and documented use. Let's delve into our cases to see how we apply these member-focused practices long before this epidemic captured worldwide attention. Next slide, please.
Thank you, Callie. Now let's look at some real-life patients who we've identified through the various holistic measures that Callie just discussed. This patient was a member of one of our clients on the West Coast, 30,000 life group, a 52-year-old female. She had a prior medical history of high blood pressure, COPD, diabetes, clotting disorder, high cholesterol, osteoporosis, urinary tract infections, which we are seeing are fairly common in the opioid abusing female population, cold sores. Her medications that she used for those, and not counting the habit-forming medications, which we'll get to shortly, were Keflex, the antibiotic for UTI, along with Coumadin for clotting disorder, Vagifem, Boniva for her osteoporosis, hydrochlorothiazide for her blood pressure, Amoxil also for UTI, Macrobid, doxycycline, all for the UTI, Qvar and Combivent for her COPD, Clonidine for her high blood pressure, and Zovrex for the cold sores. The reason that this came up for an investigation was during the analyses that we do, we noticed that she had a pattern of doctor and pharmacy shopping. Between the doctors and pharmacies, she had over 15 points of contacts between 15 pharmacies and doctors together that she was using to fill all her different opioids. She was doing multiple early refills. Many of her medications had extremely high costs, as we'll see on the next slide, for instance, the Acadians. And we also noticed she had family sharing, which is the term we use when the one member, to try to avert suspicion, is getting the same medications filled by all her family members. So if she's getting Percocet and she's hitting a limit, or the pharmacy doesn't want to give it to her anymore, she'll get more under her husband's name, for instance. Next slide, please. Now let's look at the particulars of the opioid situation here. When we reached out to our doctor, the diagnosis he gave for all of the opioids was severe low back pain. Now we reached out to the doctor, that was her primary, and we call him primary because he had most of the non-opioid prescriptions and some of the opioid prescriptions as well. When we went through the case with him, he was shocked to learn all the colleagues around him that were also managing this patient. He had no idea. The pharmacists also had no idea that this patient was filling all over. Before the intervention, she was using OxyContin 80 milligrams 4 times a day. As we know, that's usually once or twice a day medication. She was using Cadian 80 milligrams 4 times a day, also once or twice a day medication. Morphine, immediate release, 30 milligrams. She's taking 10 a day. Furosemide with codeine, she's using twice a day. And flurazepam, she's using 30 milligrams twice a day. All this for a total morphine equivalency of 940 milligrams. To put that into perspective, the average patient that goes into the hospital and needs morphine for a heart attack or whatnot, they'll start them off with 5 milligrams or 10 milligrams. This patient had a total of 940 milligrams equivalent per day. She was costing $16,000 per month. So looking at the backdrop here of these medications she's using, we'll take a moment to discuss pain management. Proper pain management. In order to prevent addiction, we need to have long-term therapy in terms of round-the-clock pain relief. It's the short-term pain relief, the constant pills that give the quick highs, the ups and downs, the peaks and troughs. That's where the high is seen that leads to the addiction. So if a patient has their pain well managed on around-the-clock therapy, and then they have a short-term just to be given when that medication is being worn off. So for instance, if they were properly managed on the OxyContin and they would take 1 or 2 morphines in between the doses as it wore off, that very often would be a proper therapy. Unfortunately, in the past, that wasn't always taught so well. Many prescribers didn't know this. We've had many discussions with many prescribers that determine that, but it is now being taught throughout, and education is hopefully going to go a long way in fixing this problem. After speaking to the doctors, locking her into just one physician and one pharmacy, which was the lock-in program that Callie mentioned previously, we got her down to fentanyl patches, 100 micrograms every 3 days. Again, long-term, round-the-clock therapy, so she shouldn't have any real pain between. Once in a while, she had a little bit of a breakthrough pain, so for that, she had morphine sulfate immediate release, 10 milligrams, PRN, Proronata, and because she did need a very high dose, we had to add MS-Contin, morphine sulfate, continue to release 100 milligrams 3 times a day. Now you see we got her all the way down to 190 milligrams morphine equivalent, almost half the dose. When converting from one opioid to another, we use an approximate 50% to 25% decrease because of incomplete cross-tolerance amongst opioids. Her cost went down to $2,000 per month from $16,000, savings of $14,000 per month or $168,000 per year. A little bit of intervention, a little bit of personal time with a pharmacist and a patient goes a very long way. Next slide, please.
Thank you, Ellie. For case 2, we have an East Coast-based member and one that demonstrates how this opioid addiction knows no boundaries in terms of age or how it truly can be an accidental overdose situation. The case at hand is a 64-year-old female with a prior medical history of anemia, urinary tract infections, arthritis, anxiety, malnutrition, and hemorrhoids. Her existing non-habit forming medications included a variety of antibiotics, Lexapro, Cymbalta, Zantac, Belladonna, iron, Clemera, Persantine, Plavix, Relistor, Chantix, and Proctiform. The reasons that led to us investigating really had to do with the call center that we have in place. They were able to identify that when the member had called in asking for early refill requests, and were able to escalate this concern over to the clinical team, who was able to then research further. It's important to have a call center staffed by a very well-trained team, one that pays close attention to detail and goes the extra mile, a team that has empathy needed to assist the customer. Thankful to our team for escalating this case, we were able to begin our interventions when she asked for that early refill request on her opioid. A sad case indeed, because this particular patient was plagued with IBS early in childhood, and as a result of that condition had surgical removal of her large portion of bowel, and therefore unable to absorb foods, opioids, and this resulted in very severe diarrhea. According to her doctor, it reported that she only had 1% body fat, although that's probably a drop higher than that. And due to the malabsorption, her opioid tolerance was quite high. She was using multiple opioids to try to obtain pain relief, but simultaneously using them to control her diarrhea. Next slide, please. We'll look at the details. As you could see, prior to the intervention, the patient was on multiple pain medications, ranging from the patch to the liquid to the Actique as needed to the OxyContin, Tentora, Percocet, Vicodin, coupled with medications for her anxiety and muscle relaxation. All of this with a morphine equivalent dosing of 800 milligrams per day and a startling cost of $12,000 per month. Taking the details of this case, we created a very customized and innovative solution that was well received by both the prescriber and the patient. It was truly a very unique case. Rather than using multiple opioids to curb the pain and via their side effects treat her diarrhea, because of her absorption concerns, we suggested the subcutaneous injectable octreotide to manage the diarrhea. Over very careful tapering of the pain meds, we, as a comprehensive team, the doctor, patient, PBM, and plan, the RX ecosystem, had only one opioid on board, and that one utilized in a pill-splitting fashion, if you will, by having the patient counseled to understand how only a quarter of the opioid lollipop could manage her pain. The RX ecosystem and the holistic approaches resulted in improved clinical outcomes, quality of life for the patient, and significant cost savings to the plan. Savings of $8,000 per month, nearly $100,000 for the year. Next slide, please. So what is the outlook on this epidemic? We see it as a balancing act. One, where progress and change are on the horizon and should encompass a twofold approach. One that addresses those currently addicted and in desperate need of treatment, and another that prevents future generations from accessing and misusing opioids. Both represent unique populations with very different needs. A new study published in the Annals of Internal Medicine offered some cause for optimism. It found that it may be possible to reduce doses for patients on long-term opioid therapy and improve their pain outcome and quality of life. Really a glimmer of hope on an issue where more research is necessary before it's settled. In order to reduce use of dangerous opioids and reduce pain, we must allow, encourage, and pay for non-opioid strategies. Strategies such as non-habit forming medications paired with alternative treatments that work, like acupuncture, chiropractor, massage, or physical therapy, all of which can help to deal with the pain, as well as counseling and therapy that help with the equally and very important mental component of how one thinks and copes with their pain and condition. Increased funding will help move people out of the pit of despair created by addiction by offering them easier and quicker access to help. 6 states have declared an opioid emergency, and approval of a national emergency fund could open up funding to these states and many more. Another encouraging sign I read recently was that the FDA chief plans to meet next month with benefit payers and administrators on how to mitigate the problem. All very good signs. We'd like to thank you for your time today and hope that the information provided will encourage further progress and collaboration as we work within our respective fields to address this very important problem. Next slide. We'd like to open up the discussion to questions and thoughts on the presentation.
Great, thank you so much. This is Jane. I'll take it back here. And as a reminder to everybody on the call, if you are interested in submitting a question, you can do that in the questions section of the control panel, which should be on the right-hand side of your screen. So we will be watching those come in and teeing them up for the BMR team. Before we get started, actually I've got some coming in already, so I'm going to go ahead and start through the questions. So this is a pretty general question, but I think it's an important one. From your perspective, what is the current state of the opioid crisis? Do you feel like it's getting better or is it getting worse? Because I think we've seen reports saying both.
I think it's a great question, and there has been a lot of back and forth very recently. There have been some articles, even in big newspapers such as New York Times, pointing up and down. But our feeling, looking at our data, looking at within and without, that it is definitely getting worse. One thing that makes it look in some studies as if it's getting better is the RX limits, where they're making it so that it's less tablets per prescription, but less days per prescription. So if you look at it, it's coming back as less days used, but in reality, it ends up being more prescriptions and more tablets. So for a total net effect of more opioids out there.
And Elliot, I'd like to add one thing to that. It's also the law of big numbers working against. So when you have an instance where the opioid epidemic, in definitionally, no matter how you're evaluating it, grows 10, 12, 15-fold, and then slows to grow a little less, you say, oh, look at this, it's declining. But the baseline of the problem has grown to such an epidemic and such a proportion, it cannot withstand that kind of growth because of the law of big numbers. But it's still the baseline. While you may see some states where there's a decline, it's still so far beyond where it was just a few years ago.
Mm-hmm. Great. This question expands kind of beyond the walls of just the United States. How is the opioid crisis viewed internationally? And what, if anything, could Americans learn from their experience?
That's an interesting question. We were just discussing it last night, myself and Dr. Penagos. I'll talk about two of the countries. I think that there are some others to talk about. Looking at Europe, Western Europe, one of the things you see is in a single payer model, they've really limited how much you can get, how many you can get at a time, how many different prescriptions you can get, and how many doctors you can see, limiting it much more than is being done in the U.S. Now, that's not to say that it's not a problem in Europe. It's a problem everywhere in the world. But looking back at the numbers, 98% of the world's hydrocodone use is still in the U.S. So clearly the problem is much worse here in the U.S. with lack of limits. Moving on to the Middle East, some countries there, also single payer models. One thing they have is you have to get approval from the single payer, the insurance companies there, to prescribe it if you're not a specialist. So your average doctor can't just go and write you a Percocet prescription without getting approval from a doctor above him. So increased controls there on who can get it. Everything is boxed in tablets of 10. So you don't have bottles that you have in the U.S. pharmacies of 500, 1,000 tablets. If you want 40 tablets, you need to get 4 boxes, and each box has its own cost. So cost goes up to the patient, and the limitation goes up. The pharmacies don't stock it. There's so many different levels there built in just naturally into the system that it also has mitigated the spread a little bit. Callie, I think you had some research in some other places as well.
Yes, thanks. Our neighbors over in Canada have an equally startling epidemic in the opioid world. What they're doing there is a multi-year strategy that they're hoping will result in successful outcomes. They call it the Safer Decision Saves Lives project. And it creates a standardized and consistent kind of data intake prior to any visit to a physician. So they've established things like 10-minute tools, pain check-in tools that are activated on the patient's visit, and then that information is therefore formatted and applied in a record that can be shared. That's a helpful tool, pain strategy tool, so that prescribers can then have access to the information.
Great. A few more questions we have coming in. So this one, what is your opinion? We've seen some larger PBMs recently move towards limitations, to example of 7-day supply limit on opioids for first-time users. There's been a lot of feedback both from the AMA as well as doctors around this particular announcement. Do you have any similar plans to do something with from your perspective? Are you implementing programs like this as well?
Also a good question. That is something we are implementing. The 7-day max is something that's fairly unanimous around the country, although there's been a lot of pushback from the AMA. Although in some cases they've fully embraced it. On the other hand, they've made statements such as the doctors fully think about these things, they understand, and we can't limit them, while on the other hand they are embracing it. It's a problem. So it is something we are implementing, exactly those programs. Most of our partners around the country and in this space are doing similar. It is a very complex problem that we need to use all these tools in.
Mm-hmm. Great. Another question, how receptive were prescribers to the outreach with therapy recommendations?
The prescribers, in the 2 cases that we talked about, they were actually great. They were very receptive. There are many cases where they're not so receptive, but in those particular cases, first of all, they were shocked to hear how many doctors these patients were running to. They had no idea. Part of it was the patients weren't being properly managed, so they were still in pain, and the doctors were happy to hear about this so they could help them with the pain. At the same time, they were becoming addicted and constantly needing more, so therefore they're running to doctors around, and their primary doctors were happy to help with that. They fully understood the importance of this, and they were happy for the fact that we gave them a way to play, so to speak, hardball to get the patient to listen, because although we did a very soft touch, the patient could have easily walked over to another doctor if we hadn't stepped in and said, hey, you know, as an insurance company, your employer has authorized us to limit you to only see this doctor, to only use this pharmacy. And then when the patient realized this is how it was going to work, they became very receptive as well. And they, playing ball is not the right term here, because they were happy to have their pain managed better, to have their case managed better. They recognized that they were addicts. They were very frank about the problem, but they were also very receptive to treating it, and they wanted to get past it, which they did. They moved past it.
I'll add that the collaborative approach here is important, and having that patient-centered mindset, and once the physician is on board that we're all here to accomplish, you know, a similar goal here. How do we help this patient who clearly understands they have a problem and needs help, just doesn't know how? How do we work as a team? Once they're on board with that and they understand we're working towards that common goal, it was easy to engage and easy to find solutions that they were receptive to. It really was a collaborative effort and a very good one for us. These 2 cases are just a couple of the very many that we take on, and we are happy to see results in clinically, in terms of plan cost and overall outcomes. So it's possible to accomplish. It goes back to the holistic approach, taking your analysis, your data, arming yourself with information to be able to have that thoughtful discussion, having empathy for the situation as a whole, understanding how sensitive it is for all parties involved.
Absolutely. letting the patient and the doctor know that our goal of getting involved is not to be the policeman here, but it's to help them get better.
Yeah, and this next question, I'm jumping ahead a little bit, but I think it speaks to some of the responses that you just provided, and maybe you might have a little bit more commentary to add. But the question focuses on, do you think it is the place of the PBM to arbitrarily decrease patients' access to opioids when the essence of the problem is the prescriber behavior? Any more you want to comment on that one?
That feeds right into the various responses the AMA has had. It's a tough balance, because as a PBM, the prescription benefit manager, we are hired by, whether it's the employer, the plan sponsor, whoever that is, for exactly that. They want us to manage the prescription benefit properly. Now, we're not their treating physicians, so it can be a little bit of an awkward place to go in and almost sound as if we know better, because we don't know the patient as well as the doctor does. But at the same time, very often, education is a problem. Physicians, very often, if they went to school 30, 40, 50 years ago, before this type of thing was a problem, they may never have received proper training on preventing opioid addiction and proper pain management. So it is a balancing act. It is the place of the PBM, but the PBM has to still remember their place as there to help the membership and the plan sponsor at the same time. It has to be very courteous with the physician, realize that sometimes there will be adversity, and come at it from that perspective of helping both the physician and the patient get the best outcome.
Nellie,
I agree, yes.
That's a great point. If I could just make one comment to that.
Mm-hmm.
Clearly that's the origination of our presentation is all about collaboration amongst the ecosystem. It's not to attack a problem that has grown out of hand. So if you look at this from a classic problem-solving mindset, obviously what was presently in place did not work. So because the problem has grown so paradoxically. So we're trying to stress it's collaboration, it's communication. It's not us summarily doing something without bringing in the 4 Ps of the ecosystem, as we had touched upon. And there's also some very scary predicate law. While I could appreciate the AMA looking at this in purely a medical term, but when you look at some of the wholesalers being sued, effectively they're being told, while it may not be your fault, it is your responsibility to know what's going on in the chain here. You can't turn a blind eye. And that's not unlike a parallel or a proxy that we look at in the banking industry, where they drive, you need to know your customer, you need to know what your customer is doing. So you can't say, geez, I didn't know they were taking place in this criminal activity. You could still be found guilty. So it becomes much more complex, and that's why we stress collaboration and getting everybody on the same page.
Mm-hmm. I agree, Tim. I'll add a point there that I believe the AMA is taking on efforts to educate and for prescribers to become more informed of strategies to combat pain that don't involve opioids. I believe that in the past it was a lack of access to non-opioid strategies that led prescribers to give these medications out, and they offered an easy answer to the pain issue, but it was an ineffective one, as we see now. As we educate prescribers or within our industries and open up to other strategies that can provide effective pain relief, I think we'll begin to see change, and that's where we all have to come together and help in that capacity. In terms of where the PBM lies, it's a unique relationship that we establish with the prescriber and determine what the patient needs and what the prescriber is asking for.
Great. Another question here is asking about how long does your clinical team typically spend on an individual case?
Well, that really varies a lot. The 2 cases we presented, they were very, very long cases. There were many hours that went into them, whether it's the calculations, the research involved in the particular cases, the short bowel syndrome, for instance. I mean, we came up with the solution for the doctor. Hey, why don't you try octreotide instead of opioids that are just not being absorbed in this malnourished patient? There was a lot of work in them. In most cases, it's not that much. It might be a day or 2 of calling all the data and arming yourself with the data before we call the physician. Those are usually 1 or 2 days worth. Sometimes we'll have to wait for the physician and the pharmacy to answer all the responses. But it's never a few hours. It's usually a few days.
Yeah, and it's an ongoing effort in monitoring and making sure that the patient and the ones in the cases that we reviewed today is just continuing progress, maintenance, watching how they're doing. They, come in back into contact with us and advise on how they're feeling, what's changed in their life, what other improvements they're making. So it's very customized and unique to each patient case. So.
Okay, the next question looks at one of the examples that you gave in your presentation, the Actique example. The patient was maintained on Actique, a drug only indicated by the FDA for oncology pain. What clinical information is typically taken into consideration when therapeutic interchanges are attempted?
Oh, that goes into an age-old question that it goes throughout, not just opioids, but in every category. Can you recommend an agent to treat something if it's not FDA approved? I think that's the focus of this question. And in most categories, we have to be very, very careful before we recommend something. In this particular case, it was a member who had almost no options. So the physician was very happy and willing to listen to any and all cases. The Actique really was the best answer because rather than dealing with pain patches that weren't being absorbed through her skin, that didn't have enough fat below it to facilitate proper absorption, and instead of trying oral opioids that weren't being absorbed because of a short bowel, having a lollipop to keep in her mouth on and off that she could just quickly take out when she felt the proper relief from her gut. That really was what the doctor liked and found to be the most effective. Now, why such a high dose? 600 micrograms is an extremely high dose. And like I said, it's for cancer pain. Well, because she had been on so much throughout her life, she needed to start at such a high dose because of the tolerance. However, because it's a lollipop, she was able to self-monitor, and being that she was motivated to lower her dose, she does a very good job of that. She is a patient we're still in touch with.
Mm-hmm. Okay. Here's a question around the limits. Can a client put their own limits in place if they do not want to follow the PBM's rules? If they wanted to limit opioid prescriptions to a 10-day supply, and then a second part, can they put plan limits in place without any clinical criteria?
As far as the PBM goes, every PBM can set their own rules. In our view, the client should have the ultimate decision power. So if a client tells us, well, these are the rules we want, we feel the client should be able to. But you have to realize that states can set their own rules to override that. No PBM can override a state rule or any federal rules.
Right. With that said, it's our responsibility to educate our clients, which is what we do. We advise them. We look at their specifics and their population, and we listen to what it is they're looking to do. And together with what we advise them, we formulate a plan that's best for them. So we take all those factors into consideration when setting up a plan to make sure it captures what it is they want and what it is they need.
Great. The next question talks about Medicaid. Is the Medicaid population more impacted from the opioid crisis? And do you think that the Medicaid expansion has fueled the overprescription issue?
Without a doubt. That's actually a statistic I was back and forth about whether we should put it in, but it was widely seen with the Medicaid expansion. In those areas where Medicaid expanded, the opioid use climbed steadily immediately after the opioid expansion because some of these opiates that people use are quite expensive. And all of a sudden, hey, there's somebody else willing to pay for the patient's drug use. So 100% it did expand. Now, private insurance pays a larger portion of it, but the Medicaid expansion now allowed for people who had no previous insurance to have somebody pay for these medications.
Okay, another question coming in. It's my understanding there is an opioid monitoring database in every state except Missouri. Will this or has this monitoring seemed to help the situation at all?
Coming from some retail experience. I've been in retail pharmacy quite a bit, and what it has allowed is a pharmacy who has a cash patient come in. Those were always patients that the pharmacist looked askance at and say, hey, why are you coming in and offering cash for this opiate? Don't you have insurance? The patient would say, well, I just got dental surgery, I need this. But there's no way to look back and see what else have they gotten. Now that these databases are around in almost everywhere except for Missouri, and they'll have it soon, it allows the pharmacy to say, no, you just got this down the street, you got this all around town. It prevents pharmacy shopping, and it's really been a great help to the independent and chain and all the local pharmacies.
Absolutely. It allows for pharmacist interventions at the point of sale, and it allows for engagement and discussion at that level. It only helps the situation.
Okay, here's an interesting question. Are you seeing trends in reduction of opioid use where marijuana is legal in certain states?
We have not looked at that specifically and broken it out in that way. I was reading an article last week that's arguing the opposite, that in states where marijuana is legal, it actually has been increasing, surprisingly, although I never thought it would go down. But the data is still fairly preliminary, and the articles I was reading, I wouldn't draw any hard conclusions from them yet. But it was an interesting take to say that the opposite of what people think seems to be occurring.
Okay, another question here. One issue we see on the PBM side is that there is not a simple way to verify that multiple prescribers are working out of separate offices or the same office. What changes do you see, if any, are coming down the line to address this issue?
Well, before addressing changes, we've come across that, but most of the time we're able to resolve it easily by either having the customer service reps contact them, get stationery from the doctor's office to confirm who's working where, or even Google searches usually resolve those questions. As far as any government controls put in place there, I don't see anything coming down the pipeline for that, although the hospitals very often are taking care of that for us as they're buying up more and more physician practices.
Okay, I think we have time for one more question. Thank you, everyone on the line. Lots of great questions coming in. And for those that we aren't able to get to, we will have the presenters follow up directly with you so you can make sure to get your questions answered. But here's the last question coming in. Where there are state limits on opioids for the initial opioids like New Jersey and New York, and the doctor does not follow these edits and they write a 30-day supply, does the DEA do audits and notifying the prescribing board of these issues?
I can speak for New York. I'm not as familiar with New Jersey right now, but I know for sure in New York that the DEA does do follow-up both with the physician and with the pharmacy, but not with the PBM.
Okay, well, that wraps up our questions. Thank you to all of you that asked great questions, and thank you to the presenters. Shelley, I'll turn it over for you for final comments.
All right, thank you, Jane. I want to thank BMR again for sponsoring today's webinar, and Timothy, Calliope, and Elliot for sharing their expertise on this important topic. Just a reminder that a link to the recording will be sent later this afternoon. And in addition, we'd appreciate your participation in a short survey that will pop up once you leave the webinar. We have 2 webinars in September coming up, and you can see some information here on the screen. The one on September 14th is sponsored, so it will be free to everyone. And the second webinar is an encore presentation of a session from our annual conference held this past March. So that one is free to both PBMI members and anyone who attended the conference. More information on both can be found on our website under the Events menu. That concludes today's webinar. Thank you again and enjoy the rest of your day.